Hello, I'm Dr. Crystal Murcia for Contemporary Pediatrics. Today I'm joined by Dr. Diane Foley to discuss sex education for children and adolescents, which is a very timely topic in light of recent media coverage. Dr. Foley is president and CEO of the Life Network in Colorado Springs, Colorado, and has been involved in the development and teaching of sex education materials. Dr. Foley, perhaps we can begin by setting straight some nomenclature. When people hear the term abstinence education, it brings forth certain connotations about the messages and content of these programs. For example, they have been criticized for not providing sufficient health information. What does abstinence education or an abstinence program really mean?
Well, I think you're right that there is a lot of misconceptions about exactly what an abstinence education program is, and I think that in reality that has changed over the years. I think when we talk right now about a quality abstinence education program, in fact, the terminology has changed to be what we call sexual risk avoidance education. I don't know if you're familiar with that term or if any of our listeners are or not, but the importance is that this type of education actually looks at risk behavior of adolescents and divides it into a couple of different approaches based on a public health model. The idea is that from a public health standpoint, what you want to do is to encourage optimal health outcomes for adolescents and children. And so as a part of that, the public health approach says that the healthiest choice is to avoid all high-risk behaviors. When you are looking at high-risk behaviors for adolescents, those are typically grouped in 5 different categories. We usually look at drug use, we look at smoking, we look at alcohol use, we look at violence, and then we also look at sexual activity. Those are the things that are reported on from the CDC on their youth behavior risk surveys every couple of years, and so those are what we track and monitor to look and see what a healthy outcome is. So on the basis of sex, then, if that approach truly is to avoid sexual risk, and we're looking at a holistic approach, then the healthiest choice is for teenagers to avoid sexual activity, particularly at a young age. Now, the CDC says that the only way to avoid consequences is staying from sex until you are, and they have a very long definition, mutually monogamous relationship with an uninfected partner. And so again, approaching that, using that as an approach for sex education is what abstinence education is. It's more than just a just say no message. It really talks about what are the risk factors and what are the holistic things that would be better, your health would be better if you waited for sex, if you decrease the number of sexual partners that you had. We know that the younger you are when you start having sex, the more sexual partners you're likely to have in your lifetime. So again, optimal health based on either pregnancy risk or STD risk or other types of emotional or social consequences, that's going to be healthier if adolescents wait until they're older to engage in sexual activity.
So does this mean that other options are not discussed, or what proportion breakdown is there of abstinence discussion versus other ways of avoiding risk?
Well, abstinence is a lifestyle, so it isn't grouped among contraceptive choices. But contraception is discussed in these programs. Contraception is discussed as a way to reduce your risk for the physical consequences that can occur. And teens are taught about the fact that using condoms does reduce the risk, certainly for certain of the sexually transmitted diseases, not all of them, and it definitely reduces the risk for pregnancy. And so that is in a category of reducing the risk as opposed to avoiding it completely.
The American College of Pediatricians advocates abstinence until marriage sex education. Setting aside any moral or religious drivers, what is the scientific evidence for the effectiveness of this type of educational approach?
Well, we have right now 25 studies that show significant effectiveness of this type of a program that have been published in peer-reviewed journals. There are about 43 other studies that are ongoing right now that are in various stages of production based on when they've started, because what happens is when you are looking for a behavior change, you have to follow that out for a number of years to be able to see if there really is an actual behavior change. It's easier to monitor intention change, attitude change, that type of thing. But when you're actually trying to look at behavior change as a result of an approach to something, it takes a longer time. And those are available, and I can make those available to you as a resource if people would like to review those further.
Just in a nutshell, because there are a lot of studies out there, what types of outcomes or intention changes have they been observed, and how does that compare with other types of education?
Well, when compared with control models, so looking at a sexual risk avoidance education versus other types of education, in these 25 articles that have been published that I mentioned to you, what we see that compared to peers, students in a sexual risk avoidance program are much more likely to delay the onset of sexual activity. They also, if they're sexually active, they are much more likely to discontinue that activity based on what they've learned. And they are also no less likely to use contraception at some point in the future when they choose to have sex. So when they're asked, kids that have been through this program and they decide to have sex, one of the arguments against this program is if you don't teach about contraception, then these kids aren't going to use it when they decide to become sexually active. And that is not the case. That has not been shown to be the case in these 25 studies.
Is there any difference in how you would approach education or how effective it has been when you look at boys versus girls?
There really isn't, and it seems to be a difference based on different programs. Some programs show a better effect with girls, some show different with boys. It's pretty evenly distributed.
So when people think of sex education, they usually think of that as the purview of the parents foremost and the educational system secondarily. So where does a clinician fall into this mix?
I think the clinician has the opportunity to partner with the parents and to help the parents either become more informed about the issues that their adolescents are going through, or to help to reinforce what it is that the parents are interested in that their students should learn. You know, I believe as pediatricians that our job really should be most about prevention. Prevention of harm, prevention of unhealthy choices. It's the way we approach alcohol education. It's the way we approach drug education. We are all about really emphasizing the fact that the healthiest choice for adolescents is to avoid this high-risk behavior at this point. And so as a pediatrician, I think that should be emphasized. Now, do I think that there are students that are going to go ahead and use drugs even if I tell them it's unhealthy for them? Absolutely. But it doesn't change my message to them that the healthiest choice for them is to not do that. It's the same thing with sexual activity. Do I think there are students that are going to make a choice to be sexually active even if I have said to them it's healthier for you to wait until you're older, until there are other maturity factors that have come into place? Absolutely, they're going to make that choice, but it doesn't change the fact that I still believe the healthiest choice for them is to emphasize that avoiding that activity is the healthiest choice for them.
Well, thank you, Dr. Foley, for joining me today. This has been Dr. Crystal Murcia for Contemporary Pediatrics.